Good morning everyone. Today's topic for the seminar is Candiduria in infants and children. I am Dr. Neha. I will be presenting today's topic and my moderator is Dr. Gagandeep sir. So this is going to be my outline here. I'll start with the introduction, then proceed to explain the epidemiology, then pathogenesis, then management, under which I'll explain the lab diagnosis, some imaging modalities and treatment, and finally the summary. So introduction. Now Candiduria is defined as presence of yeast cells belonging to the Candida species in urine, and the significant colony count is taken as cutoff is 10 to the power 5 colony forming units per ml. Now coming to the epidemiology, which is the interaction between agent, host and environment. So to start with the agent, now Candiduria, the agent isolated here can be Candida albicans or it can be non-albicans Candida. Now among the non-albicans Candida, the examples are Candida tropicalis, Candida glabrata, Candida krusei and Candida parasolosis. Now coming to the prevalence of all these agents. Now this is a study which was done in AIIMS and RMN, and here in this study they found that the albicans, Candida albicans was isolated in 43% of the isolates and non-albicans species was isolated in 57%. So this is one of the recent studies in which Candida albicans is less than 50% and the non-albicans species are actually predominating now. Earlier it used to be predominantly Candida albicans. Now, this is another study in which 50 patients were taken and 16 patients were reported to have Candiduria. And in this case we can see that 11 patients had Candida albicans and 3 patients had both Candida albicans and tropicalis and 2 patients had only Candida tropicalis. Now this is a study which enumerates, this is a table which enumerates multiple studies. So here we can see that there is a lot of variation when it comes to the prevalence of albicans and non-albicans species. So the albicans, it ranges from 19% to as high as 68%. And the next most common comes out to be Candida tropicalis. In certain cases it as high as 43%. Now coming to the host. The risk factors which are responsible for Candiduria are, one is first most important is indwelling urinary catheter. Now second is neurological procedures, then the use of broad spectrum antibiotics, then certain congenital anomalies of the urinary tract, then the neonates who are very low weight, very low birth weight or extremely low birth weight, then certain immunocompromised state like neutropenia, organ transplant or steroid intake. Now the question arises, why infants are more vulnerable host? It's because the epithelial barrier of the infants are not developed. And second reason is the normal flora of the infants is not developed. And third is the immune response of infants is weaker. So Candida, as we all know, it's part of the normal flora. And here if the immune response is weak, then it can invade. Now coming to the environment. Now majority of the Candiduria cases are seen in a hospital setting. And community acquired cases are extremely rare. It only happens in certain underlying conditions like diabetes mellitus. Now here one interesting thing to notice, in case of hospital setting, the source of the infection in majority is again endogenous. It's not acquired from healthcare workers or it's not acquired from the hospital surfaces. It's actually from the endogenous flora only. But the infection happens mostly in the hospital setting due to certain urological procedures or catheters or something like that. Now coming to the pathogenesis. Now Candida species, as we all know, is part of the normal flora of the gastrointestinal tract, genitourinary tract, the upper respiratory tract and skin. Generally Candida itself, its adherence to mucosa is poor. So the chance of invasion of an intact epithelium by Candida is very less. And there are certain conditions which predispose to invasion. These conditions include a breach in the epithelium due to certain urological procedures or some surgeries. Then urinary tract obstruction. This is because if there is obstruction, the urine backflow can occur, and the urine washing out of the urine is not happening in these cases. Then the third thing is immunocompromised conditions, because the host immune response is weakened. And the fourth is use of broad spectrum antibiotics, because the normal bacterial flora is affected in this, and the candida can manifest and it can invade in these cases. Now coming to the virulence factors. So virulence factors, the first factor is the expression of certain adherence mechanisms, namely the adhesions. Now the certain examples of adhesions include cell surface manoproteins, now glycosaminoglycosides, then additional manoproteins which attach to the integrins, and fourthly the mannan, which is a complex polymer of mannose that binds to certain cellular surface proteins. Then second virulence factor are the enzymes, for example aspartyl proteinases and phospholipases. So these enzymes, they can directly act on the tissue and they can directly hydrolyze the tissue, which will lead to invasion of the candida. Third is the biofilm formation, which I'll explain in detail later. Next is the dimorphism. Now dimorphism refers to the change from the yeast form to the hyphal form, and this is considered to be an important factor in invasion because the hypha is the form which invades the tissues. But here one interesting point to note is that in case of Candida glabrata, it does not have any hyphal form, but it has also been found to invade. So this tells us that dimorphism is not the only mechanism that is acting here. There has to be some other mechanism acting as well. Next factor is thigmotropism, which refers to the response to surface topography. That is, the candida, we can sense the surface topography and it can induce hyphae formation along the surface of the tissues or the mechanical the instruments. Next is galvanotropism. Galvanotropism refers to the response to electric field, that is the concentration of the ions, and this is determined especially by the concentration of calcium ions. Then next is the phenotypic switching. In certain cases, the phenotypic switching happens in which the candida can switch from white colonies to opaque colonies, and these opaque colonies express certain different genes which have higher virulence, and this can predispose to invasion. And another is evasion of host immune response, and this is especially seen when the candida can evade the complement system. So these are the various mechanisms of pathogenicity. First, as I explained, this is adhesions, and this is done by the expression of certain adhesions in which the cells, here we can see, they're attaching to the host cells. Now second is the dimorphism, in which the yeast cell is changing into hyphal forms, and this is the hypha that is expressed. Now this one explains the thigmotropism and invasion. So this is the thigmotropism. Basically it's the cell which is sensing the surface of the host and it is inducing hypha formation, and then it is inducing certain invasions, after which the hypha can penetrate the tissues. This is the example of phenotypic switching, in which the white shiny colonies of the yeast can change into a more virulent opaque colonies. And this is the biofilm formation, which I'll explain later. And these are certain fitness traits. Basically, these are the certain heat shock proteins which are expressed by the candidal cell. They can overcome certain stress responses, and they can also induce the uptake of certain ions, and they can regulate the pH, which will induce hypha formation in an easier way. Now coming to the biofilm formation. Now biofilm is formed by candida in three phases, that is early phase, intermediate phase, and maturation and dispersion phase. Now in early phase, there is only attachment of the yeast cells to the surface. In intermediate phase, there is hyphae formation and there is some production of extracellular matrix, and there is also acquisition of the nutrients, that is carbohydrates and proteins. Now in the last phase, that is the maturation and dispersion phase, so here we can see that the biofilm has established itself, it is adherent to the surface, and here the hyphae, the yeast cells lie towards the surface, and the hyphae extend from that, and here the extracellular matrix formation has almost completed, and from this part will act as a nidus from which the yeast cells will disperse and can disseminate into the other parts. In case of Candida glabrata, here we can see that there are no hyphal forms visible here. Now the question arises that why biofilm is important. It's because biofilm will act as a constant source of shedding. That is, the yeast cells will go on shedding from the nidus of infection. So it creates a difficult situation for the clinician that the patient is going to have persistent candiduria. So it's going to be difficult whether to consider this as a true candiduria, that is a true UTI infection, or it is colonization. And the second thing is that due to if at all a patient has a biofilm formed in the catheter, the drugs which are given to act on the cells, they will not penetrate the biofilm and they will not act on the pathogen. So the patient is not going to respond to treatment. Now coming to the routes of infection. Now Candida infection can happen in two types, that is ascending infection and descending infection. Now in case of ascending infection, the source is almost always a colonization from the invading catheter, and again here the source is endogenous, that is from the normal flora of the person. And in this case, here only kidney is involved, unlike descending infection in which kidney along with other organs can be involved, but kidney is the most common organ which is involved. And majority of the true Candiduria are descending due to hematogenous spread. Now in case of ascending infection, mostly the renal pelvis and the renal medulla are affected, unlike descending infection in which the cortex is affected more, and in imaging modalities we can see certain micro abscesses which are formed in the renal cortex. And this ascending infection is more common in case of diabetes or anatomic abnormalities of the urinary tract. So this case is more important in case of neonates and children. That is, in case of ascending infection, if a child has some congenital anomalies of the urinary tract, then that should be caught and that should be corrected. And ascending infection tend to be unilateral and descending infections tend to be bilateral. Now coming to persistent Candiduria. So if a person has persistent Candiduria, there are certain groups of high risk patients in which persistent Candiduria should be addressed because there is increased risk of formation of fungus balls in them. And these groups include diabetics, urinary tract abnormalities, those patients who have this, and the neonates. Now, how is the disease course and the pathology different in premature neonates versus the adults? Now, in case of neonates, the polymorphonuclear leukocytes in neonates, they may not be able to completely ingest and kill the yeast cell, which is normally done by adults. Then there is also higher propensity for fungus ball formation with resulting obstruction. And this is not true in case of adults. Another thing is renal impairment is much more common in neonates as compared to adults. Like in adults, if they have Candida UTI, it is much less likely to proceed to renal impairment, but this can happen commonly in case of neonates. Another thing is the symptoms which are presented. In case of neonates, the symptoms tend to be non-specific. That is, the symptoms tend to be apnea, bradycardia, glucose intolerance, decreased urine output, even thrombocytopenia. But in case of adults, the symptoms tend to be specific. That is, flank pain or something related to the kidney itself. Now, here is a so as we see, now you have to differentiate between infection versus colonization. Now, how to differentiate infection versus colonization? Now, as we saw that most patients with Candiduria are asymptomatic and the yeast simply represent colonization. And it is very difficult to differentiate between colonization and true bladder infection. Now, infected patients who are truly infected, they will have dysuria, frequency, suprapubic discomfort, but it is also possible that these patients present with no symptoms at all. And another thing is pyuria. If pyuria is actually common in patients with a chronic invading bladder catheter. So it is a non-specific finding, that is a positive pyuria cannot indicate that it is a true infection. But here the point to note is if there is absence of pyuria, then that can hint towards it is colonization. And the presence of pseudohyphae in the urine or the number of colonies growing in the culture, they also cannot distinguish colonization from true infection. So here the question arises when to ignore Candiduria and when to intervene in Candiduria. So there are certain cases in which Candiduria must not be ignored at all. Now these are the cases. First is the extremely low birth weight neonate, that is when the weight is less than 1000 gram. Second is if a person is neutropenic. Third is the symptoms persist. In these cases, they must be evaluated for disseminated disease. Fourth is if the person is presenting with certain signs of sepsis, because Candiduria might be the first sign of invasive infection. So they should always be evaluated for disseminated infection. Fourth is, last is the patient, if the patient is planned for any urologic procedure. Okay. Now coming to the diagnosis, here the investigations can be microbiological or radiological. I'll first describe the radiological investigations. Okay. Now radiological investigations include ultrasonography of the renal system, CT scan, here the 18F fluorodeoxyglucose PET scan, PET CT, then scintigraphy using certain radiotracers that are specific for fungal infections. Now, I'll just explain this briefly. The radiotracers for fungal infections. Here, two interesting findings are there. One is radio-labeled fluconazole. Now, in one study, which was an animal study, it was found that radio-labeled fluconazole, that is 99M technetium conjugated to fluconazole, it distinguished Candida albicans infection from bacterial infection and sterile inflammatory processes. That is, it was very specific to point out the Candida albicans infection. Now, another marker is radio-labeled iodine 123 chitinase. And in the same study, it was found that this marker, it accumulated only in Candida albicans and Aspergillus fumigatus and not in the sterile inflammatory processes. And this marker was also found to correlate with the number of viable fungal cells. So these are two promising modalities which might be used in future in humans as well. Now, the findings of radiological investigations include multiple microabscesses in the renal pelvis as well as the renal cortex, and fungal ball formation. Fungal ball formation is basically the fungus along with the necrotic debris, which is viewed in the radiological in the film. That is, this is the example of a fungal ball in the image here. Two fungal balls can be visible in the left kidney, in the renal pelvis, and there is non-general and there is some general findings like diffuse inflammation surrounding the lesions. And some other general investigations include the CBC, in which in one study it was found that elevated monocyte count was found to be correlated with Candiduria. Now, this is one image of a patient in which a PET scan was done, and here we can see this is the initial scan in which no treatment was done. Here you can see the lesions of the candidiasis. The patient had invasive lesions, and initially these lesions were thought to be bacterial infections, so the patient did not respond. And when the antifungal treatment was given, the patient started to respond, and here in the last image we can see that the lesions have resolved. So FTG PET can be a good modality to see response to therapy. Now, coming to the microbiological investigations. Now, first, what are the appropriate samples in these cases? First sample, of course, is the urine, and the urine sample can be midstream urine, especially the older children, then suprapubic aspirate in case of neonates, and catheter specimen from the sampling port. And if dissemination is suspected, that is, if the patient is showing any systemic signs or symptoms, then it should also be sent for a blood culture and also for serum beta-D glucan. Okay. Now, the investigation that are done in lab can be divided into the test which can detect the yeast and the test which can identify, that is, speciate. So detection include first is the wet mount. Now, in the wet mount we can also see budding yeast cell as well as we can also see pus cells. Now, here the presence of pus cell is a non-specific finding, but the absence of pus cell can hint towards colonization, because pus cells, the presence of pus cell will indicate tissue invasion, and since the pus cells are not present, so we can conclude that this might be colonization instead of true infection. Second is the Gram stain, in which budding yeast cells are seen. In this, the cells appear as ovoid cells with pseudo-hyphae, and they are Gram positive and deeply purple stained. And third is the culture on SDA plate, that is Zavros dextrose agar plate, in which the semi-quantitative urine culture method is used using a 10 microliter fixed volume loop. Now, coming to the tests which are used for identification of the yeast, they include germ tube test, corneal agar test, chrome agar, and Marditov. So this is the example of the germ tube test. Now, germ tube test is done by using a suspension of the yeast with 0.5 ml of pooled sera, and it is incubated at 37 degree for 2 hours. Now, after 2 hours, it is a drop of the sera is taken on a slide, a cover slip is put, and it is observed in high power. And this is the finding. This is a positive finding, and germ tube test is only positive in case of Candida albicans. It is not positive in non-albicans species. So this is a presumptive identification test for Candida albicans. And here you can see that the germ tube should be, the wall should be parallel, and there should be no constriction at the beginning of the cell, and it represents a true hyphae. And ideally, a positive and a negative control should also be taken along with the test stream. Now, this is the morphology on cornmeal agar. Now, on cornmeal agar, we can study the spores since it's a sporulating media. So, first is the Candida albicans. Here we can see terminal chlamydospores are seen. In case of Candida glabrata, we can see only the yeast forms are seen and no hyphae or pseudo-hyphae is seen in this case. Now, Candida parasilosis, here the thicker, larger size hyphae and pseudo-hyphae are seen here. And Candida cruzi, again ovoid cells, elongated budding cells are seen, and Candida tropicalis has a typical pine forest-like appearance. Now this is the chrome agar. Now in chrome agar, we can directly detect the species based on the color. So Candida albicans gives a greenish color, light to medium green color, and Candida tropicalis will have a steel blue color. And here Candida dubliniensis is similar to Candida albicans, but the color is little darker. And Candida krusei will have a fluffy rose pink colored growth. And Candida glabrata here is colorless. So this is the outline of the management. Now here if we find a positive Candida in urine culture, then first we have to suspect that it might be colonization or contamination. So we have to confirm it by a second urine sample to rule out colonization and contamination. So if the second urine sample comes out to be negative, then we can safely rule out contamination. Now we have to check for pyuria. Now after checking for pyuria, if pyuria is absent, then we can also hint towards colonization because tissue invasion has not occurred in this case. And if pyuria is present, then it usually supports Candida infection. And then we have to proceed to species identification of that is it albicans or is it non-albicans. And then we have to see localize the exact anatomic site or the level of infection. Now the anatomic site can be simply like asymptomatic candiduria, then it can be cystitis, candidiasis, renal candidiasis, and Candida pyelonephritis. Now in case of asymptomatic candiduria, there are certain high-risk groups in which treatment is indicated, but mostly antifungal treatment is not indicated in case of asymptomatic candiduria. Only the removal of the risk factors is indicated, that is discontinue the unnecessary antibiotics and remove or change the urinary catheter if feasible for the patient. Now the rest three conditions, that is Candida cystitis, renal candidiasis, and pyelonephritis, treatment is indicated in these three cases. That is all symptomatic cases of candiduria should be treated. And in these cases again in Candida pyelonephritis, we have to see if any urinary stasis or any urinary obstruction is happening, then adequate drainage should be done. And in all three cases the treatment is given, which I will explain later. Now according to IDSA guidelines, the treatment of asymptomatic candiduria, now treatment for asymptomatic candiduria, antifungals are not recommended except certain high risk groups, which I will explain later. Now here the first line of management is elimination of the predisposing factors. That is, if a patient has a catheter, then you just remove the catheter or change the catheter if it is feasible for the patient. And if the patient has any obstruction or congenital anomaly, then correction of that will lead to spontaneous resolution of candiduria. Now there was a study in which it was seen that candiduria resolved without any specific treatment in 76% of the cases, in which the number of cases observed were 861. In another study, it was seen that fluconazole was superior over placebo in clearing candiduria, but at a 2-week follow-up, candiduria rates were similar between both the groups. So it indicates that treatment is not going to be beneficial in the long run. Now, what are the high-risk groups in which asymptomatic candiduria has to be treated? These groups include three groups, that is neutropenic patients, very low birth weight infants, and patients who have a planned urologic procedure coming up. Now I'll discuss what is exactly the treatment in these cases. So in case of neutropenic patients, the first line of management is echinocandins, that is casfofungin, in which loading dose is 70 mg and then maintenance dose is 50 mg daily. Next is micafungin, the dose is 100 mg daily, and third is anidulafungin, in which loading dose is 200 mg and then 100 mg daily. One alternative to this is amphotericin B lipid formulation at a dose of 3 to 5 mg per kg daily.
This is not for candiduria. This will be for renal parenchymal infections.
Okay.
Because echinocandins don't go into the urinary tract. So this is for renal parenchymal infection.
Okay. So next group is the very low birth weight infant group, in which amphotericin B deoxycholate is the first line of treatment, that is dose is 1 mg per kg daily, and one alternative is fluconazole at a dose of 12 mg per kg daily. And the third group are the patients in which a urological procedure is planned. They include the first line treatment is again oral fluconazole, that is 400 mg at a dose of 6 mg per kg daily, and one alternative is amphotericin B deoxycholate, that is 0.3 to 0.6 mg per kg daily for several days before and after the procedure. Now coming to the symptomatic candiduria. Now according to IDSA, all cases of symptomatic candiduria has to be treated, and these are the recommendations. First, for fluconazole susceptible organisms, oral fluconazole is recommended at a dose of 200 to 400 mg, that is 3 to 6 mg per kg daily for 2 weeks. for fluconazole resistant Candida glabrata, amphotericin B deoxycholate at a dose of 0.3 to 0.6 milligram per kg daily for 1 to 7 days with or without oral flucytosine at a dose of 25 milligram per kg 4 times daily. Now, for another option for fluconazole resistant Candida glabrata is a monotherapy with oral flucytosine at a dose of 25 milligram per kg 4 times daily for 2 weeks. Now, for Candida krusei, amphotericin B deoxycholate at a dose of 0.3 to 0.6 kg per daily for 1 to 7 days is recommended. Now, along with these, as we saw in asymptomatic case also, elimination of urinary tract obstruction is strongly recommended. And for patients who have nephrostomy tubes or stent or any kind of instrumentation in place, then that removal or replacement of that tube should be considered if feasible. Now, some other treatment modalities include amphotericin B deoxycholate bladder irrigation, which is done at a dose of 50 milligram of drug is taken and it is mixed with 500 ml of sterile water, and the irrigation is done daily for 5 days. It may be useful in cases of cystitis due to fluconazole resistant species such as C. glabrata and C. krusei. Now, to summarize the management here, if Candiduria is detected, then there are 4 possibilities. That is, it could be contamination, it could be colonization, it could be a UTI, that is a true infection, and it could be secondary to candidemia. Now, to eliminate contamination, if contamination is suspected, then a second sample should be asked, and if the second sample comes out to be negative, then we can safely rule out contamination. Then we can safely conclude that initial sample was a case of contamination. Now, colonization, UTI and candidemia are not possible to distinguish on the basis of microbiological investigation. So, next step is proper clinical evaluation of the patient. That is, the patient should be categorized whether the patient is asymptomatic or if the patient is symptomatic. In case of asymptomatic, it should be seen that if the patient belongs to high risk group or not. Now, if the patient does not belong to high risk group, then no antifungal treatment is indicated. Only removal of the predisposing factor like the urinary catheter, that is indicated. And if the high risk group, it is present in the 3 high risk group as I enumerated, that is neutropenia, very low birth weight babies and planned procedure people. In those cases, antifungal treatment should be given. Now, in case of symptomatic, in case of UTI, if the person has UTI, then antifungal treatment should be given, and further the patient should also be evaluated to see if the patient has any systemic symptoms. And this is especially true in case of infants, because any infant who presents with Candida UTI has to be evaluated for systemic symptoms to check for disseminated disease. And if the patient is clinically unstable, then antifungal treatment should be given. Again, the patient should be evaluated for candidemia. Investigation should be sent for blood culture, and imaging should be considered to see if any fungal ball formation is there or the neonate or the child has any congenital anomaly of the urinary tract. Now, what are the outcomes of Candiduria? And this is a study which was conducted in which the outcomes following the Candiduria in extremely low birth weight infants was evaluated. They evaluated 2 factors, that is mortality and neurodevelopmental impairment. So, mortality and NDI were evaluated. So, in this study, out of 1515 infants were enrolled, 34 infants had Candiduria, that is 2.2% of the cases had Candiduria, and it was concluded that extremely low birth weight infants with Candiduria are at a substantial risk of death or NDI. Candiduria in extremely low birth weight preterm infant should prompt a systemic evaluation, that is blood, CSF and abdominal ultrasound for disseminated Candida infection, and it warrants treatment. So lastly, to summarize the topic, I would say that it is very important to identify true Candiduria, and majority of the Candiduria will resolve with removal of the predisposing factor, that is catheter removal or correction of the predisposing factors. Now, if there is any systemic symptoms, then it warrants a proper evaluation for dissemination. And as we saw earlier, Candiduria is a marker for greater mortality. And then the drugs that should be chosen which achieve adequate concentration in urine, only those drugs should be given, namely fluconazole, flucytosine, amphotericin B and micafungin. So with this I would like to conclude. Thank you.
So can you, because a lot of people have joined late, can you go back to the slide where you had distinguished ascending and descending infections, because that is very important to understand how to differentiate ascending and descending infections. And majority of the times, the serious ones are the ones which are descending infections, because first there is renal involvement as part of candidemia. There is seeding of the kidneys, followed by the microabscess formation in the kidneys, and then even there is passage of or transfer of the yeast cells from kidney down to the ureter, and it causes cystitis. So and it is said that in cases of disseminated candidiasis, almost if we've seen disseminated candidiasis autopsy cases, almost few studies have shown almost 90% involvement of kidneys. So kidneys are one organ which have very high susceptibility. The exact reason is not known why the kidney gets involved, but usually the rate is very, very high. And the next organ to be involved in disseminated candidiasis is heart, where again 40 to 60% of the cases, if you do a autopsy in disseminated candidiasis, there is some involvement of the heart. So renal involvement and heart involvement is important. And renal, so the question ultimately comes is, if you have candiduria, whether this is it represents involvement of the upper tract or not, because if it is involvement of the renal parenchyma proper, then you have to treat the patient aggressively, because the outcome is very poor. Mortality can be in untreated cases, mortality can be somewhere around 80 to 90%. So it can be an indication that there is disseminated candidiasis. So yeah, this is important. Can you just discuss this again, and then we'll move to a few more points in treatment. So go slow.
So here the route of the infection can be two, that is ascending infection or descending infection. Now in case of ascending infection, the source is almost always colonization in the indwelling catheter. Unlike in case of descending infection, which are the majority of the case, here the source is due to hematogenous spread, that is candiduria is happening secondary to candidemia. And in this case, the only organ involved in ascending infection is kidney. But in case of disseminated infection, kidney happens to be the most common organ involved, but other organs like as said heart and even every organ of the body can be involved in candidiasis. And ascending infections tend to affect more renal pelvis and renal medulla, and descending infection affect the cortex more. Here microabscesses are seen in renal cortex, and this ascending infection tend to be unilateral versus descending infection, which tend to be bilateral. And ascending infections are more common in cases of diabetes or anatomic abnormalities of the urinary tract. And descending is also common in case of cases of immunocompromised people, but anomalies of urinary tract is a specific finding which predisposes the person for ascending infections.
So here also there's an important point to remember, especially if you are evaluating a person with candiduria, especially the high risk group. So complications of the two. If you have a sort of a descending infection where the renal parenchyma is being involved first, you see a lot of microabscesses. You may sometimes see fungal ball in the renal pelvis. But if it is at all an ascending infection, so lot of times you see unilateral perinephric abscesses can be there, and emphysematous lesions can be there. So if there is any evidence of gas formation around the kidney on radiology, that again gives you an indication that probably this is an ascending type of infection. So it's important to distinguish, because ultimately treatment would depend if you can differentiate. One more point, there are certain articles which do mention is utility of showing fungal casts. I'm sure you must have read that if you can make smears and if you can stain them with pus, and if you can demonstrate presence of fungi in those casts, it's almost a sure shot indication of a descending infection, that the renal tubules are getting involved, and the casts are basically they are molded in the tubules only, and they are representing involvement of the renal tubules. So that is important to understand. Again, drugs. Again, I would like to reiterate here that there are only three major classes of antifungals which are to be used. Upfront, if a patient you think that a high risk patient is there and you need to start empirically an antifungal, almost always, even in our setting, we don't have fluconazole resistance which is so high. So you can very comfortably give fluconazole. If the patient is sick, you can even give fluconazole up to 400 to 800 mg in divided doses. And because the concentration of fluconazole, it's a small molecule, it is almost it is secreted unchanged in the renal tract and it gets concentrated. So usually the MIC that is achieved in urine of fluconazole is much higher than the required for killing of the candida. So fluconazole should be empirically the first drug of choice. Then, because we know that if you have identified the species, that the patient is affected by a species which is fluconazole resistant, then you can move on to a deoxycholate amphotericin B, because liposomes they don't pass through they're not filtered out, so they don't achieve any concentration in the urine. So it's the deoxycholate liposomal amphotericin B, usually at a dosage of around 0.3 to 0.6 mg per kg, that is what is given. And if not, sometimes you are unable to even give amphotericin B because of its toxicity, then flucytosine, which is otherwise people are not very comfortable giving. A lot of studies have shown that flucytosine can very comfortably given. You just need to monitor its side effects. It can be given at something around 100 mg per kg per day in divided doses, and for around 7 days. And another thing, if once you've started treating a patient of UTI and you're not very sure that whether it's ascending or descending infection, almost it should be treated for at least 14 days. That is what is recommended. That treat the patient for 14 days, irrespective of whether your urine is coming positive or not, because you are treating it as, it's better to treat it as a disseminated infection which is involving the kidney, and treating it for 14 complete days. So that is again which is important. And I don't think we've had any questions. Any questions anybody would like to ask? So can you also explain the radiological modalities? Maybe you can just, because a few of our faculty have joined late, so maybe you can go back to recent modalities on radiology and nuclear medicine that are you can be utilized for.
Yes, so the investigations, as I said, it can be microbiological, it can be radiological. Now here in radiology, ultrasound, CT scan, FDG, PET CT, apart from these three, some newer modalities like scintigraphy using certain specific radiotracers for fungal infections. Now they can detect candida. So these are two markers in one of the study which it was done on mice. So here they used radio-labeled fluconazole, that is 99M technetium fluconazole conjugated marker, and it could distinguish Candida albicans infection from bacterial infection as well as from sterile inflammatory process which was taken as a control. Now another marker is chitin, that is iodine 123 labeled chitinase. Now this marker could detect Candida albicans as well as Aspergillus fumigatus infection in mice, and it did not detect sterile inflammatory processes, again which was taken as a control. So these two are two promising modalities in future, and they can be used in future to detect infection as well as they can be used to monitor therapy and the response to therapy.
Okay, so can you just quickly enumerate the complications of Candiduria?
Candiduria, if it is a true infection, Candiduria, then it is usually secondary to candidemia. So all the complications of candidemia, that is the person can proceed to sepsis. Then there is, in case of infants, as I pointed out in one study, neurodevelopmental impairment can be seen.
Ascending?
In case of ascending infection, it can reach the renal pelvis, it can reach the renal parenchyma as well, and there it can cause ascending infection, that is inflammation, pyelonephritis, and emphysematous pyelonephritis, and Perinephric abscesses can
fungal
also be done.
balls.
Fungal balls can also.
And you haven't spoken about prostatic abscesses. There are a lot of reports of prostatic abscesses in as a complication of long-term catheterization in elderly or who are diabetic. So they are the patients who ultimately land up with prostatic abscesses due to candida.
Okay.
And treating a prostatic candidal abscess secondary to a candiduria is extremely difficult, because they are mostly multiloculated. It's not, drugs usually don't penetrate those loculated abscesses. There has to be a sort of a direct intervention. Either you put aspirate all the abscesses, or you put a small catheter there to drain it. So it's difficult to treat. But if you're giving a drug, mostly fluconazole, because it penetrates well into most of the tissues, fluconazole does act. One more important thing which I just remembered is, if you can discuss candiduria in renal transplant patients. What is the significance? So if a patient who has just undergone renal transplantation, he or she has candiduria, are they at an increased risk of developing invasive candidiasis?
If candiduria is already present in a patient who had undergone transplant, then the risk is high, because the transplant procedure itself predisposes the patient to an immunocompromised condition.
I'm not talking about that. But the transplant has just occurred, and post-transplant you find that there is candiduria. Should you be worried?
So exactly, I'm not aware. I have to look it up.
So all the studies that have been done, they show that actually renal transplant, it was thought that in a transplant patient it will be more complex or it will be more severe, but mostly it isn't. So it should be taken as routine only. You just need to give, maybe just a change of catheter can do away with the colonization, or so it's not that renal transplantation would per se increase the chances of invasive disease. So that is an important thing to remember. So we have a question by Dr. Shayan, and he says, any role of micafungin?
Yes, among all the all the echinocandins, the micafungin is indicated because its MIC is achieved, adequate MIC is achieved in urine. So micafungin is a first-line treatment, not first line, but it is an alternative among all the echinocandins. It is the chosen alternative.
Salvage. It is actually a salvage, because we have 3 drugs which can be given: fluconazole, you have amphotericin B deoxychloride, and flucytosine. But if at all you don't have any other, if the patient is already on micafungin and still you have candiduria, then or you're starting a patient on micafungin, you don't need to additionally add a drug. The micafungin will take care. But it's not that we are saying that this is not a blanket statement that echinocandins cannot be used. As I said again, if there is renal parenchymal involvement, then caspofungin, micafungin, allogenofungin, all 3 can be used. Only when the lower urinary tract is involved, micafungin has some role. And anything about amphotericin B bladder washes, because there is a lot of interest, and we have seen that in one or a certain group of patients, amphotericin B bladder wash can be useful. So can you just throw light on that?
Amphotericin B bladder wash initially was used a lot, but now some evidence shows that it is not that indicated in some cases. But in some cases, like as I pointed out, fluconazole resistant C. cruzi or Clabrata infection, this should be done. And if the person is not responding to oral therapy, and if the person is having any nephrostomy tube or any kind of instrumentation already present, and the wash also it can be done easily, then in some cases it is indicated. But now it is generally not indicated as compared to earlier times.
Okay. So there's a question by Dr. Neto. He's asking, how many days can the candiduria persist after removal of a catheter?
In the studies I did come across, it varies a lot. Like it can persist beyond 14 days, and it can also spontaneously resolve the moment the catheter is removed. Even the next 2 to 3 days sample can be taken, and it can come as negative.
Yeah, so that is true. That it's very difficult. There isn't a cutoff that once your catheter is removed, immediately there will be a few. But in majority, it gets if it is simple colonization due to the catheter, it will definitely resolve within the next 48 to 72 hours. But if at all there is a biofilm formation which is involving the inner part of the urethra, it can persist for many days. So there isn't a specific cutoff for that. Any other questions? I don't think so. There are any more questions. So thank you so much for attending.
Thank you, everyone. So I'd like to conclude with this. Okay,